Okay, with that, I want to pass over to Dr. Hygiene, the WHO WPRO Western Pacific Regional Office Director. If you're online and can hear me.
Yes, this is Hygiene. Thank you very much. So good morning and good afternoon to all from WHO Western Pacific Region Office in Manila. I'm Dr. Hygiene, the Director of Healthy Environments and Population Division. It is a pleasure for me to greet all our WASH colleagues globally in the region, in government, NGO, and in our country offices. I also wish to greet our WASH colleagues in Geneva and thank all who are contributing to this training webinar today. I hope you are all keeping safe. So welcome to this online training webinar promoting the improvement of WASH in healthcare facilities to stop and prevent COVID-19 tools and experiences, organized by WHO and UNICEF and our Health and Environment Unit here in WPRO. So indeed, we all know the COVID-19 virus is transmitted through respiratory droplets or contact. Contact transmission occurs when contaminated hands touch the mucosa of the mouth, nose, or eyes. The virus can also be transferred from one surface to another by contaminated hands. Consequently, hand hygiene practice is extremely important to prevent the spread of the COVID-19 virus, not only individual protective measure, but also suppressing community transmission. This is why our regional guidance recommends securing access to hand hygiene facilities as a priority action in all national COVID-19 response plans. The hand hygiene is most often performed with water and soap. As you know, alcohol-based hand sanitizers are another option in some locations. Hand hygiene with soap and water is generally very cost-effective given the reduction in other common infections and no additional equipment is needed. Indeed, it is for these reasons that WHO issued a recommendation on obligatory hand hygiene against transmission of COVID-19. One or several hand hygiene stations for hand washing with soap and water or for hand rubbing with an alcohol-based hand rub should be placed in front of the entrance of every public building, including schools and school health care facilities and private commercial buildings to allow everyone to practice hand hygiene before entering and when leaving it. We all also know that many healthcare facilities, especially in rural areas of the least developed countries in our region, suffer from poor access to basic wash services. We therefore encourage you all to also prioritize as much as possible joint national and local action to improve wash in healthcare facilities at this vital moment in time. It is through awareness and capacity building tools, such as this webinar, that we can effectively learn more and better convey important, sometimes life-saving messages to our staff and counterparts in countries. Once again, I wish to thank the organizers and participants and wish you all a fruitful and productive webinar. Thank you.
Super. Thank you very much for that introduction and opening remarks. I'm going to pass the controls over now to Maggie Montgomery, who's joining us from Geneva. Maggie, let me pass the controls of the presentation to you. Over to you.
Okay, Perfect. Well, good afternoon, everyone, and thank you for joining us today. I'm just going to give a quick overview of some of the key technical details around WASH and coronavirus and some of the specific measures that we need to make sure we're reinforcing, particularly at the national and the community level, to ensure that we have good prevention through namely good hand washing, but as well as safely managed water and sanitation services. So let me see. I'm trying to advance here. Sorry for the delay. Okay. Just very quickly before I begin, we've seen many of your names just looking at the chat box in our WASH Fit technical series. And if you haven't joined those webinars, I encourage you to do so. We've had 2 so far on water and healthcare waste, and we have 3 more, including one tomorrow on hand hygiene. So you can find all the details here. We'll be sharing the slides and encourage you to join if you want to know more specifics about each of these technical areas within healthcare facilities. Sorry, I seem to have a bit of a delay. Okay, so these are the latest figures. We have about 1.8 million global cases, and deaths are around 117,000. As you can see, the greatest cluster of cases right now are still in Europe and in the United States. But as many of you are aware, the outbreak started in China, and we're increasingly seeing the number of cases rise in the Asia and the Pacific region. Sorry, Arabella, I'm having a bit of a problem here. Apologies, the advancing. Arabella, it might be easier if you do the advancing.
Yes, let me do it.
Okay, apologies everyone. Okay, so we'll keep going. So just very quickly, I wanted to orient you to 2 important documents that both give quite a bit of emphasis on WASH, but also are being used to drive the overall response. So the first is the UN-wide plan. It was launched 3 weeks ago now. There's 3 key pillars, and WASH is obviously critical around containing the spread, and particularly in healthcare facilities where we know healthcare workers, as well as any other patient or individuals in the facilities, are at increased risk. But we know WASH is also really important around assuring that people have the basic necessities to live, that some of these essential services around water and sanitation, not only that those workers can continue to work and be protected, but that all individuals can benefit from those services. Within the WHO response, there's 8 pillars. Now, there's a brand new plan that was just launched this morning, and I haven't taken a close look at it, but I encourage you to do so. It's online. Within the 8 pillars, WASH is obviously very critical and closely linked to infection prevention control. And within the WASH team at Geneva, we've been working very closely with the IPC team on all the new technical guidance that's coming out, as well as some of the operational issues. But it's obviously also important for case management. It needs to be within country plans and monitoring efforts, as well as around the community engagement aspect. Next slide. So just the 5 main takeaways of WASH and COVID, and I've posted here the technical brief that we developed with UNICEF. We have an updated version. It's been approved. It should be online later today. So I encourage you to go to the WHO site, and we'll give you the link at the end to look up that updated brief, which provides a lot more detail, in particular on sanitation and safe treatment of fecal waste, as well as on hand hygiene. So the first one is hand hygiene is critical, especially for a disease where we don't have a clear course of treatment and we don't have a vaccine. The hand hygiene becomes a really critical prevention measure, especially in situations where we have workers who are still in the communities and in countries where there's starting to be a easing of some of the lockdown measures. Environmental hygiene is also really important, and luckily this virus is easily inactivated with common disinfectants. So typical measures to disinfect surfaces need to be taken. For water and sanitation, all our existing guidance applies. So there's nothing new that needs to be done, but COVID is another reason to be investing in the safe management of drinking water and sanitation along the entire chain. On the investment side, it's really important that WASH investments are being done at the national and the community level. And these investments are going to have lasting impact for communities. And I think that's really important, because some of the other investments are one-off for commodities or maybe for short-term measures. But we know WASH investments can far outlast this pandemic. And then lastly, as I'm sure you're all aware, that there's other benefits to investing in WASH, not only for diarrheal disease, but also for dignity, human rights, and related benefits. So next slide, please. So just very quickly, I won't go into a lot of details. I'm sure you've seen this infamous image of the coronavirus with the lovely crown. It is relatively fragile in the environment because it's surrounded by a weak lipid layer, and this layer is easily penetrated by soap, by common disinfectants like chlorine. And compared to non-enveloped human enteric viruses, the ones we're probably more familiar with, like norovirus, rotavirus, hepatitis A, the coronavirus will be inactivated much more quickly. Current evidence suggests that likely infectious COVID virus may be excreted in feces. We still only have one study where they've cultured the virus from feces, but we have many now examples of evidence from wastewater treatment plants from raw sewage, so not the treated sewage, but the raw sewage where they're finding RNA fragments. So all that to say that the risk of transmission through feces of an infected person appears to be low. Next slide. So I'm not going to go through all the details here, but this just summarizes what we know about survival of human coronaviruses. And these aren't always, most of these actually aren't of the SARS coronavirus 2, which is the current virus which is causing coronavirus. But from all the work that we've done in the environment, other types of coronavirus, including SARS coronavirus 1, which I'm sure many of you are familiar with, given that that outbreak really affected your part of the world, it seems to behave very similarly in the environment. So in summary, it lasts from days to up to 2 weeks or more in sewage. Just wanted to highlight that on the water, that evidence is from dechlorinated water. So if the water is chlorinated, the virus will be killed and inactivated quite quickly. Next slide. Okay, so what are our guidelines and what do we really need to be taking into consideration? Well, for safely managed water, we are advocating and strongly encourage using a water safety plan approach. And I really look forward to hearing from all of you, because many of the countries that you come from have been doing water safety plans in the communities for years now. And this approach is what we've based our WASH Fit, which is a risk-based improvement process for improving water, sanitation, healthcare waste, and hygiene processes within healthcare facilities. Want to highlight that the chlorine residual is really important because it ensures not only that the virus has been inactivated, but that water is safe from recontamination, which we know is quite common. And where such chlorinated supplies aren't available, it's important to use point of use treatment. And WPRO has a very strong program in looking at the performance of water treatment products, many of which now we see are being manufactured and sold to healthcare facilities. So they're treating larger amounts of water than obviously would be treated in a household. We know boiling, some high performing ultra or nano filters, solar and UV, as well as appropriately dosed chlorine are very effective in removing viruses. Okay, next slide, please. On safely managed sanitation, WHO for the first time launched guidelines on sanitation and health in 2018. It follows a very similar model to the safe management of water, and that along the entire sanitation chain, so from the toilet to containment, conveyance, treatment, and the end-use disposal, there needs to be thought into how we're not only handling feces, but safely treating feces. In particular, the plumbing is very important. And we have some evidence from the SARS outbreak that it was likely transmitted in several apartment buildings in Hong Kong through improper bathroom drains and improper ventilation through fecal matter that became aerosolized. There is some indication that there may be examples of that from the current outbreak, though we don't have much published evidence on that. So regardless, it's really important that bathroom drains are sealed, that there's backflow valves on bathroom sprayers and faucets. In regards to actual toilets, and this is our standard recommendations, that staff and patients should have separate toilets. So this just avoids one potential source of contamination. And where it's possible, COVID patients should have their own toilets, or at least COVID patients that are cohorted should not be sharing toilets with non-COVID patients. The regular cleaning and disinfection of bathrooms is really important, and those who are doing the cleaning or handling any kind of fecal material should have on proper PPE, which includes a face mask, which includes a shield for the eyes, includes thick rubber gloves and sturdy boots. Next slide. Hand hygiene. This is obviously critical in healthcare facilities in particular. WHO has been running a campaign on hand hygiene for over 10 years now, and May 5 marks the annual Hand Hygiene Day in healthcare facilities. And what we know is that it requires a multimodal approach. So there needs to be many things happening at once. So there needs to be a systems change, about how hand hygiene supplies are procured, how they're monitored. There needs to be training, regular evaluation and feedback is important, reminders, as well as a whole culture of promoting and demonstrating good hand hygiene. Some critical actions are obviously procurement of adequate quantities of hand hygiene supplies for staff, the patients, and the visitors. And thinking ahead for potential increased demand in services means that more hand hygiene supplies would be needed than normal. Refreshers on hand hygiene training, as well as reminders and communications about its importance. Next slide. In regards to healthcare waste management, again, just want to emphasize that our standard guidance applies around segregation, treatment, and safe disposal. Obviously, waste that is generated through the care of COVID patients is infectious and should be treated as infectious waste. Waste that is generated, for example, at home, where COVID patients are either being isolated or recovering, doesn't need to follow a separate waste chain. It doesn't, it's not feasible to be setting up a chain, nor do we have any evidence that there's, highly increased risk. But such waste in homes or in communities or even in waiting areas, for example, of clinics, needs to be put in bins that are bagged, and those bags need to be sealed and put into a regular garbage disposal, which is then picked up and disposed of in a controlled land site. Also, it's important to conduct hand hygiene after throwing away any waste. So whether it's a tissue or it's bandages that are being used. Waste workers, like sanitation workers, also need to be protected with the appropriate PPE. And maybe just the last thing to highlight here is that the additional PPE that's being used by the healthcare professionals in terms of aprons, in terms of masks, it means that there could be additional waste that's being generated. So healthcare facilities need to think about how they're going to more regularly, for example, empty waste bins because they're going to fill more quickly, and how they're potentially going to treat more waste, either by treating it on-site or contracting a provider to take it away and treat off-site. Next slide. On cleaning, what I want to highlight here is that, and I've mentioned this already, existing common disinfectants, excuse me, are effective, such as 70% ethyl alcohol, 0.1% sodium hypochlorite, or up to 0.5% sodium hypochlorite for blood and spills. Studies from Singapore and China indicate that recommending cleaning techniques are effective. So it's really good to know that in care rooms, in bathrooms, where viruses were detected, virus fragments were detected on surfaces after the cleaning was done, they were not detected. So we know the common practices work. Specifically on the linens, they should be, and these are bed sheets or clothes worn by patients, they should be washed, machine washed at high temperature with detergent or soaked in warm water, and then in chlorine. This document here came out last year by CDC. From WHO, we provided quite a bit of input and goes into a lot of detail around cleaning. So I encourage you to take a look at that. Next slide. On the hand hygiene, and it was great, this was already mentioned in the opening, but just wanted to emphasize that WHO has launched global recommendations on obligatory hand hygiene in public areas as well as healthcare facilities. We know now, unfortunately, there's huge gaps in access. We have 2 in 5 healthcare facilities lacking hand hygiene at point of care, and we have 3 billion individuals globally without basic hand hygiene facilities at home. So there's huge gaps, but we also know that actually solving this problem is probably easier than solving some of the safely managed and safely managed water and sanitation issues. So what does that mean? It means there needs to be obligatory hand hygiene in front of all public buildings. I have an example here from Indonesia of public hand washing stations in Geneva now. Anytime you go to the grocery store, you'll see alcohol-based hand rub. So we're seeing really innovative solutions around the technologies pretty much throughout the world, which is fantastic. Obviously, in terms of the maintenance and the use, and those are probably 2 of the more challenging items, it's really important that there's engagement with civil society, NGOs, or private providers that can help make sure that these facilities are being maintained and used appropriately. Next slide. Okay, just a few more details. For the hand hygiene materials, the optimal options are water and soap or alcohol-based hand rubs. And for healthcare facilities, we're really advocating that these 2 must be the 2 options, that if you're a healthcare facility, you should be able to acquire either soap or alcohol-based hand rubs. And we'd love to hear from all of you on whether or not this is a challenge and what you're doing. We do know that ash and mud can work. There is some precedence for its use in rural communities in Asia, for example, and even a water alone can be somewhat effective in large part because of the rubbing action and then the washing away. Water doesn't need to be of drinking water quality. The amount of water used can really vary, and we also recognize there's many areas where there's water scarcity is a big concern. So developing facilities and helping people to understand that you actually don't need a lot of water, that you can use a low flow device, or making sure you turn off the water while you're rubbing your hands is important. Yeah, and I think just the last thing to highlight here is that we've seen a lot of private sector engagement around the alcohol-based hand rubs, and we have examples from Kenya, from Switzerland, from the United States, where in particular breweries, because they already are making another type of alcohol, are switching over to making ABHR, pharmacies, and other types of entities. Next slide. Okay, so what can you do? So I think first of all, and many of you are national leaders and national influencers, is to make sure that WASH is included in country COVID plans. So WASH in healthcare facilities obviously is a key priority, and that needs to be specified, but also WASH in other types of settings is important. I think it's also important to make rapid wash improvements in healthcare facilities, particularly those where COVID patients will be treated. And this requires doing a rapid review. If it hasn't been done already within WHO, we have the wash fit indicators, which can be used to do that kind of review and prioritization. It's also really important to strengthen support to the water, sanitation, and hygiene workers. And this means making sure they have the gear, the training, and hand hygiene to keep safe, both at home and on the job. Installing hand hygiene facilities is really important, and this includes healthcare facilities, and not just the providers, but also those visitors that are coming or bringing patients to be seen. And then lastly, making sure that water and sanitation providers have backup supplies and contingency plans to deal with issues, for example, of people not being able to pay tariffs, plans if certain water supplies are no longer functioning, as well as making sure they have enough disinfection chemicals and fecal indicator and chlorine testing equipment. Next slide. Okay, so this is my last slide. You can download the technical brief on the WHO COVID WASH IPC site. As I mentioned, there'll be a new one up there today or tomorrow, but all the key recommendations remain the same. I've listed many other documents here where you can find more details. So with that, I will hand it back over to the host and look forward to the discussion. So thank you.
Super. Thank you very much, Maggie, for that presentation. And I see there's a few questions in the chat box related to things you've mentioned. So hopefully we'll address that during the Q&A session shortly. I was asked just to give a very quick update about WashFit, and then we'll pass over to presenters from Vietnam and from Laos. We're going to share some of their experience about what they're doing in response to the COVID outbreak. So many of you on the call, I think, are already familiar with WashFit. You're either using it or have attended trainings or webinars, which we have when we've gone through the tool. Over the last few months, we at WHO with UNICEF have been working on some updates to the tool. So just wanted to explain briefly what those updates were and when you can expect to see those revised products. So WashFit, I won't go into the details now, but is a risk-based improvement tool for wash and healthcare waste management services in healthcare facilities with the ultimate aim of improving quality of care. And it's now being implemented in over 30 countries. And over the course of the last 5 years, we've been getting feedback from countries and from users. And based on that feedback, are undergoing a number of updates to the tool. So reviewing and revising the assessment tool, which forms the basis of the WashFit process, to simplify it for primary healthcare facilities and also to include indicators for advanced level services and bigger facilities, so hospitals, for example. We're also developing a simplified version for supporting facilities to respond to the COVID outbreak. So with not many resources and not much time, what are a few simple things that can be assessed and improved that are most important? And those are based on some of the recommendations that Maggie just presented. Also including updates on climate resilience, and that's something that many of the countries in Western Pacific region are grappling with and are increasingly wanting to have more guidance on how facilities can become more climate resilient, more green. And we've been learning, particularly from the experience of Vietnam and Philippines, both of who have policies and standards related to greening healthcare facilities. Also including more on gender and inclusivity and how to make facilities more accessible for those with disabilities, and providing some guidance on use of WashFit in emergencies, whether that's climate-related extreme weather events or conflict or any range of emergencies. We've also been updating the training package, and those new modules will be available by the end of this week on the WASH in Healthcare Facilities Knowledge Portal, which the link you can see there, washinhcf.org, and we'll be providing a revised guide in the next couple of months. So please watch this space for more updates. If you're already using WashFit and you have some experience to share, we'd love to hear from you. And there's an email address there to get in touch. How have you been using the tool? How do you think it could be improved? What have been the successes? What have been some of the challenges? Any information would be very welcome. And WHO and UNICEF are publishing a new global document with an update of the global status of WASH in healthcare facilities at the end of this year, and we'll be including a number of country case studies in that document. So again, if you have experiences to share, then please do get in touch, because it would be good to include some of your experiences in that document. Just linked to the knowledge portal, I just wanted to draw your attention to that. If you're not familiar with it already, please do visit the site. We'll be uploading lots of resources related to COVID-19 there, as well as there's lots of resources for general information on WASH in healthcare facilities. So we have examples of national standards, meeting reports, guidelines, training materials, presentations. So do explore some of the resources that are available there. And there's also a function for you to submit your own resources if you have national standards or other documents that you think others would find useful and interesting. Okay, so with that, I want to, oh, sorry, there's one more slide there. That's just a list of the countries that we know so far are implementing WashFit or are planning to. So as far as I know, within the WPRO region, Cambodia, Laos, Philippines, and Vietnam are already implementing WashFit. And as you can see, many other countries in other regions of the world. Okay, with that, I want to pass over to our colleagues from Vietnam who are going to give a presentation. And perhaps I'll ask you to introduce yourself, as I don't want to mispronounce your name. So colleagues from Vietnam, are you able to speak? And,
yeah. Hello, everyone. Can you hear me?
Yes, we can hear you. Over to
Yeah.
you, and just let me know when you want me to move the slides on.
Yeah. My name is Nguyễn Thị Liên Hương. Please call me Hương. I am Director General of Health Environment Management Agency, Ministry of Health, Vietnam. So today I would like to give you a brief presentation on healthcare waste management for COVID-19 in Vietnam. Next slide, please. My presentation has 3 parts. Next slide, please. The first one is about the status of COVID-19 pandemic and control policy in Vietnam. Next slide. Next slide, please. Up to now, Vietnam has 267 cases. No death is reported. Since the beginning of February, Vietnam has applied quarantine policy. All people arrived at Vietnam from other countries will be quarantined in appointed facility or hotels operated by Army. Confirmed and suspected cases will be quarantined at hospitals. Cases have a close contact with suspected cases will be quarantined at home or residence for workers. Next slide, please. And now Vietnam has 110 laboratories can provide SARS-CoV-2 testing. 294 hospitals provide COVID-19 treatment. Since April 1st, Vietnam has gone into 15 days of nationwide social distancing and self-isolation at home. Therefore, the number of health examinations at healthcare facility decreased by about 32%. So we assume that the amount of healthcare waste may decrease accordingly. Next, please. Vietnam already developed a national plan to respond to COVID-19 pandemic at 5 levels. Now Vietnam is at level 3. There are more than 20 confirmed cases in the country and less than 1,000 cases. Next, please. And I would like to move to section 2. Healthcare waste management for COVID-19 depends much on the existing established regulations, practices, and surveillance system on healthcare waste management. Vietnam currently have nearly 14,000 healthcare facilities. Next, please. For the past 10 years, Vietnam has established a comprehensive regulation framework on healthcare waste management, from environmental protection law to government decree and ministry circular. Key components of healthcare waste management is regulated in the Ministry of Health and Ministry of Environment joint circular. Next, please. Medical waste is classified into 2 main categories: hazardous medical waste and non-hazardous one. Hazardous medical waste is divided into 3 types, and waste relating to COVID-19 falls into infectious waste. Next, please. In Vietnam, medical waste must be segregated, classified, and collected at the source. Then is temporarily stored at storage, department storage. Twice a day, waste will be transported to hospital storage and treated on-site or off-site at centralized treatment facility in municipal. Next, please. Vietnam discourages hospital to build new on-site incinerators and strictly monitoring and inspection of existing on-site incinerators. Eco-friendly technologies and centralized incineration technologies are prioritized. Next, please. Medical wastewater is collected from wards and toilets to a treatment plant in the healthcare facilities and must meet the national standards after being treated. Next, please. Vietnam has a quite strong healthcare waste management, surveillance, and inspection system from central to local level and at healthcare facilities. Health sector is a focal point for medical waste management. In the healthcare facility, infectious control unit is responsible for waste management. Next, please. Training on medical waste management is regulated and implemented for 7 different audiences every year. Next, please. To respond to COVID-19 pandemic, what has Vietnam done in terms of healthcare waste management? Based on features of coronavirus, status of COVID-19 pandemic, existing regulation and practice recommendation from WHO, Vietnam has developed guidelines on healthcare waste management for COVID-19 at hospital, quarantine facility, hotels, at home, and residences. The guidelines include the whole cycle of medical waste management. Next, please. COVID-19 waste is classified into 2 types: highly infectious waste and infectious waste. Highly infectious waste generates from laboratories for SARS-CoV-2 testing, which is pre-treated by autoclave or microwave as labs. After pre-treatment, waste is classified as infectious waste. Next, please. COVID-19 infectious waste generates from COVID-19 treatment area at the hospitals. Mask, nose and mouth wipes of people who are quarantined in quarantine facility, hotel, at home or residences, from areas where confirmed cases outside hospital are detected, from people who have a close contact with confirmed and suspected cases, including their PPE. Infectious waste is segregated in a yellow color bin with yellow lining bags inside. When it is collected, the first bag must be tied and then put in the second yellow bag with a label COVID-19 waste. Next, please. People are involved in waste collection, transportation, storage, and treatment must wear proper PPE and wash hands after finishing the process. Next, please. COVID-19 waste is collected twice a day, transported and treated daily. For medical wastewater, this disinfection process must be supervised strictly at the healthcare facilities. Till today, after applying strict and proper measures, COVID-19 waste has been collected and treated on time, properly, and meet national standards. There has been no overload of healthcare waste management in Vietnam. There has been no reported cases of COVID-19 relating to medical waste so far in Vietnam also. Next, please. Sorry, could you please go back to the, okay. So we think that the existing established medical waste management, monitoring and surveillance system has played a very important role to Vietnam's combat to COVID-19 pandemic. Providing proper and timely guidance for COVID-19 waste management is essential. Ministry of Health now ensure that Vietnam has enough PPE and waste management material to respond to 3,000 confirmed cases. Ministry of Environment, in collaboration with Ministry of Health, is developing a plan of medical waste management for the pandemic at level 4 and 5. So that's all for my presentation. Thank you so much for your listening.
Great, thank you so much for your presentation. If there's no specific questions now, I think we'll pass on to our colleague from Lao PDR, and then I think we'll then afterwards hand over to Alex, who will be leading the question and answer session. So are our colleagues from Laos able to unmute and begin the presentation?
Hello.
Hi, Togus.
Hi, how are you?
Great.
So
We can hear you. Please go ahead.
So on behalf of WHO in Lao team, so I'm going to present what experiences we have on implementation of the wash-free tool in the country and what lessons we have learned. Next slide. So Lao PDR has established regulatory framework for wash in healthcare facility that includes National Basic Environmental Health Standard, which was approved in 2017 and implementation started in 2018. So also healthcare waste management regulation revised and national training program established. So, and then cannot see. Okay. 5-year action plan for rural wash, including institutional wash, has approved by MOH last year. And facility level improvement is equally important to translate newly established policy, regulation, and standard into action at the health facility level. So after 3 years establishment of the regulatory standards and regulation framework, the country started implementing facility level tool. So in 2017, wash fit tool introduced, master trainers trained, and pilots started in one province, and center level training and capacity building established. In 2018, the pilot project completed, and based on evaluation, wash fit implementation design was done, and national provincial trainers training followed. And then wash fit tool and slide of the training program updated. From 2019, it has been linked with climate change, because one of the risks is climate change, and flood, drought has been affected. So many hospitals has been affected last 2 years, and some wash facilities destroyed and damaged. And with support from the climate change project, wash fit has been scaled up in some provinces, and where climate change is main issue, and flood and drought, vulnerable hospitals implementing the wash fit. So basic supply, including water testing and basic healthcare waste management equipment and supply provided to those hospitals implementing wash fit last year. So next slide, please. So I already explained that one. Sorry. Health facility level improvement, I already explained. So next one, please, Fabiola. Yeah, thank you. Key achievement was the wash fit pilot successfully done, tool adopted in the country, and also it is considered good practical tool, and also flexible tool, able to add more indicators, standard indicators based on the existing standard and also needs. That's why we added some climate and disaster risks in the wash fit tool. And the tool was good to improve leadership role of central, provincial, and district level managers. And some managers supported funding support to the implementation of wash fit. So key area for improvement was operation and maintenance. And before starting wash fit, operation, maintenance, functionality of wash facility was 20% in some hospital. After wash fit implemented, 100% of all wash facility was functional and clean, and reached to the standard, basic standard level. So it shows visible improvement. It shows also effectiveness of the intervention. And so our main goal to make this tool everyday functional, should be part of daily activity, daily function. So also the good achievement was the mid-level staff, very well trained and also motivated. They are doing good change, and so they are main workforce implementing this tool. Also, cleaning staff very well engaged from the beginning. And next one is main challenge, infrastructure and operation maintenance was very weak, and climate change. Also, healthcare waste management weakest part in the most of rural hospitals. So, and then when we design facility level training, and so we include the separated healthcare waste management training. And facility level training and technical support requires more time and efforts because implementation plan includes several steps I will explain later on. And monitoring, also technical support, requires staff time, motivation, and commitment. Those are main challenges. Next slide, please. So how we design the implementation of wash feed in order to overcome mentioned challenges. So first step, at the time when WashFit started implementing, during the pilot project, it was discussed and agreed to start from TOT training. And then TO training at provincial and district level conducted a 3 days training with extensive PowerPoint presentation, discussion, and 1 day field work. And then after that, all trainees divided into several groups. And then all group consists, one group has 2 trainers. So they provide training at the facility level. And facility level training includes 5 steps of WashFeed tool and set up committee at the hospital, do assessment and develop improvement plan. And then next step, implementation starts. After 2 or 3 months, usually central staff visit again, do monitoring visit and on-site mentoring support, and also organize 2 days healthcare waste management training. And after 2 or 3 months, provincial district team jointly conduct second monitoring visit and also provide on-the-job training and support. And then after 6 months, this cycle takes 6 months, and then organize experience sharing workshop, giving opportunity for non-WashFit and hospitals or WashFit implementing hospitals. They share experiences. This year, we are going to organize experience sharing workshop, and scale-up plan will be done. Next slide, please. Climate resilience wash service. This is important for improving wash in healthcare facility. So many healthcare facilities face challenge related to flood and drought recent years. So we use a WashFeed tool for assessing and also rehabilitating wash services which is affected by flood to make it operational, make it functional again in one province. And so 5 hospitals affected by flood, they use WashFeed. So we appreciate that new version of WashFeed includes part related to climate change and adaptation, disaster risk and reduction. This shows one of the example of WashFeed training, which was conducted last year in Savannakhet province. Next slide, please. How it is contributing the COVID response. So generally, when wash pit implemented, it's encouraging to set up wash in IPC committee. So terms of reference is very wide there. Also, standard of implementation standards is wash and IPC standards, which already covering hand hygiene, environmental cleaning and disinfection, healthcare waste management, including prevention from needle stick sharp injury, and also ventilation included in the wash standard. So IPC and wash committee at the facility level established, they are very well connected. Two teams are working together. So one of the rapid assessment to assess IPC and hospital readiness included some questionnaire related to wash and waste management. And based on that, training materials and developed for the healthcare workers in the hospital for preparation of the COVID response. So one of the important topic of the training is IPC, which is covering healthcare waste management issue and hand washing and environmental surface cleaning and disinfection. So one of the modules of wash pit is covering surface cleaning and disinfection. So that part has been used for non-healthcare settings also. So we have developed guide and SOP for cleaning and disinfection in airport, public transport, hotel, guest house, and food establishment based on WHO guidance document. And now MOH is implementing the guide and providing training for the public and private sectors, giving demonstration training on how to disinfect and clean, and also several communication awareness raising materials, posters developed for public, private sectors, community, and also healthcare workers. Last slide, please. So based on wash pit experiences, the government is now working on integrate with the DHIS2 system to monitor wash in healthcare facility. And basic questionnaires from the wash pit was taken and added into DHIS2, and also the facility level survey data collection is ongoing. So scale-up plan, implementation of the wash pit in all healthcare facility reflected in the 5-year action plan for rural wash. So more partners are collaborating, and WHO, UNICEF, SNV are now under consultation and discussion to provide support to MOH and National Center for Environment and Water to give them assistance in assessing current situation and developing target and roadmap towards SDG and improving the current situation and also scaling up the wash pit in all healthcare facilities up to 2025. Thank you.
Great, thank you so much, Turgos, for that presentation. With that, I'll hand it over to Alex to lead us through the rest of today's webinar. So Alex, are you able to speak?
Thank you. Do you hear me?
Yes, we hear you loud and clear. Go ahead.
Okay. So here I am. It is a pleasure for me to hear you all gathered here around this very important topic. And for now, I have been able to write down a few questions that I actually already shared with Maggie. So Maggie, you would know what the main queries are. You have also responded to many of them already. But nevertheless, let's just read them out fast. What about the recommendation to use hot water for hand hygiene? Turbidity, there's a question on turbidity. Does it need to be less than 5? Another question now from Japan is about the use of hypochlorite solutions for hand washing. It's becoming popular. Would you think that is a recommendation? And then a very important question from the Philippines is how would you see, how do the WHO guidances apply for groups, vulnerable groups, vulnerable communities? And one last question for you, Maggie, is what about guidance for countries that are now constructing new hospitals? What would you recommend in terms of the approach to have a very good wash, specifically also wastewater management? Thank you. Over to you, Maggie.
Okay, thank you, Alex. That's a lot of questions. And let me try, but also invite our other speakers to comment, because I think they also may have some insight. So, and please remind me if I've forgotten anything. First of all, on hot water is not necessarily recommended for hand hygiene. We have fairly good evidence that alcohol-based hand rub and water and soap are very effective, using obviously the appropriate technique and the amount of time, which is 20 seconds. So the water doesn't necessarily need to be hot. The soap or the alcohol hand rub alone will remove the virus. Even water alone, if you have no other option, and it can be just normal water, it doesn't even need to be water of drinking water quality, can remove a log or more of the virus or of fecal matter from someone's hands. So yes, hot water not necessarily necessary, but you may need hot water, for example, for disinfecting medical devices if you don't have appropriate chemical disinfectants. About vulnerable communities, yes, this is really important, and obviously especially an issue in major urban areas where you have people living very close together. We've been working with UNICEF and the World Bank to try to come up with plans for how temporary services can be made available. So trucking, putting in satellite treatment plants for sanitation, quickly putting in new water points, and obviously having to have someone manage those water points so you don't have crowding. But yes, those communities that are living in very cramped and unsanitary conditions need to be given special consideration. And this is in line with the SDGs anyway. So the SDGs is calling us to leave no one behind. And so this is an opportunity to try to address some of those more challenging areas. And at least in the immediate short term, you know, there is funding that is being made available. So I think being able to take advantage of that, of those additional funds that are being made available by the international community as well as by many national governments. There were some questions around turbidity and water chlorination, and thank you, Terry, for providing a link to some guidance. I also provided the link to the WHO drinking water guidelines. Generally, yes, the turbidity should be less than 1, but we know in some places that's not practical. So it's recommended that turbidity is less than 5. Regardless, it's really important to check that the residual has been achieved after the contact time. In the work that we've done on testing household water treatment, we found that even non-turbid waters can have a higher organic load, which would require additional chlorine. So, and the organic content of natural waters can vary with rain, with other inputs into the water source. So it's really important to check your residual and dose the dosing as appropriate. Okay, and I think the last question that I remembered, and I should have written them all down, Alex, because you had many, was about temporary hospitals and clinics and stadiums. What do we do about the waste, and as well as the water and sanitation services? Maybe I'll start with the water and sanitation. I would not be setting up any temporary facilities without making sure those facilities either already have water and sanitation services for fecal waste, or that those are put in first, because it will be very difficult after these large stadiums and other places are like the beds and everything is put inside, and then realize that there's no water and sanitation services. So those need to be planned for in advance, and obviously planned for the maximum occupancy, excuse me, or the number of people that those facilities should hold. In terms of the waste needs to be segregated even in those facilities. So I realize they won't probably have incinerators or any way to treat the waste. So the waste will have to be, the infectious waste will have to be taken off site. And again, that needs to be thought out in advance. You know, can the appropriate trucks, can they reach the site? You know, what potential services are already available that could take the waste to either a nearby hospital that potentially has extra capacity to treat waste, or a dedicated treatment site. So that's really important. I'll stop there, Alex. If I missed anything, please remind me.
Okay, Maggie, thanks a lot. I will not let you alone right now, because there are two more questions. Very important one. What about evidence of coronavirus in drinking water? Where do we stand? And then you mentioned earlier, yes, we need to look at healthcare waste with a little more attention, because there'll be more waste produced related to PPEs, etc. The question is about, would you recommend increasing the staff, a number of staff that are in charge of dealing with the hospital waste? Over to you.
Okay, great question. We have not found the coronavirus in drinking water, and there's been no evidence that other types of human coronaviruses have been found in natural water. So as I said, the virus is particularly fragile, not stable. So it's unlikely. That said, in areas where you have water that is highly impacted by sewage, there obviously is that potential there. And again, that's why we're recommending that all drinking water needs to be disinfected or treated in some way with a treatment method that is effective against viruses. And I listed those in the slides. In terms of the waste workers, and I'm trying to look at the chat too at the same time. I see there's a question about the number of personnel and cleaners for a given area. That's a great question. I don't know if there is a particular number. I will definitely look it up and talk to some colleagues who are more familiar in that area than I am. But I think it's a good point, and I do think that it would be important to think about increasing capacity both on the cleaning side, because cleaning will need to be done more regularly, as well as on the waste side, just in terms of handling the extra load. In those two areas, the waste and cleaners are areas where typically, even in the normal times, there isn't enough staff. So I can see in this situation, they will be especially stretched. So we will get back to you on, are there any ratios that can guide planning, but certainly would also just monitor the situation in your own facilities, and obviously be in close communication, not only with the waste workers and the cleaners, but the other medical staff who could, tell you whether or not waste is getting regularly emptied, or rooms are getting quickly cleaned and disinfected after patients are being discharged?
Thank you very much, Maggie. Lovely. Thanks again for your presentation and for answering the question so well. I believe that we will have these questions also collected, and we can share them with the answers to all the participants. At the moment, we have a question for our colleague from Vietnam, Director General of VHEMA. We are wanting to know from the Philippines is a question, what are the chemicals that are being used in the disinfection booths that you mentioned, and how effective is this? Over to you. Thank you.
Thank you. As I reply to you, the disinfection booth is not allowed to use in Vietnam because they use chlorine to spray into the human body. The human body, and according to our knowledge and also the recommendation from WHO in Vietnam, office in Vietnam, chlorine spray is not recommended, and it's very dangerous for the respiratory system, and also for the vulnerable people such as old people, children, and people with diseases like pneumonia, something like that. So in my country, for the last month, I think last 2 months, there are some companies, they design and they produce disinfection booth and then sell to some agency. And then after after that, the Ministry of Health already asked them to stop, and also provide the information to the community about the booth, about about the dangerous of using the booth, and also we organize like a scientific committee to look at the booth designs. And I think on yesterday or the day before yesterday, the committee already concludes that the disinfection booth is it means disinfection cannot be used in Vietnam right now. Yeah.
Mm-hmm. Thank you very much. Yes, I believe that this decision you have taken in Vietnam is also the one that WHO is recommended, because certainly if you disinfect people like using a disinfection product on the person may harm the person, but it probably will not do much to the virus inside the person. So thank you very much, right? Yeah, that is great.
Welcome.
Thank you very much for your presentation. Excellent. And for now, I have seen here one more question for, again, Maggie or Arabella, and that is coming on the issue of recommendations to have FRC of 0.5 during emergencies. And would this apply for hospitals that are already receiving piped water?
Yeah, so I'm happy to take that. I mean, it's a good question. Again, if I were a hospital, I would be checking the water supply at the outlet of the faucets and the sinks within the hospital to see if there is still a chlorine residual. I would also contact the water utility to get their latest data to have some assurance that there is a chlorine residual. If there isn't, you know, my first response, especially if you have a well-managed pipe supply, would be to ask the utility provider to make sure that they're dosing appropriately. If that's not possible, putting in additional chlorine would be necessary. Again, I just want to emphasize that over-chlorination can also be a problem, and it means that not only will people not use the water, but the water can be harmful on the skin as well if there's too much chlorine. So yeah, finding the right balance is important. But I think the first thing is just to check to see what actually is the residual in the water in the outlets within the hospital.
Thank you, Maggie. I think the questions now at the moment have been dealt with. I personally have also one for you, maybe, and Arabella, and that is in how far we can see WHO now, maybe together with UNICEF, providing specific guidance for, as mentioned in the first question, for vulnerable groups, for let's say, communities in remote areas, in rural areas, where the situation is quite different. It is possibly a situation where people have less risk of being contaminated by the virus if they are already somehow isolated, but at the same time, they really are not having access to the medical care, etc. So where could we find, or where have you seen some guidance for that kind of settings? Over to you.
So maybe I'll start, and then Arabella, please, you can add in, especially based on your Wash Fit experience. So vulnerable groups is a wide range of groups, right? And I think, you know, once you start to break it down into the specific types of vulnerable groups, the potential intervention becomes a bit more clear. As I already mentioned, like urban areas and slums and informal settlements are one, and certainly World Bank and others are producing quite specific guidance to their country offices and to be used within the grant and loan packages which they're developing for COVID. And that really is about providing potentially temporary or longer term services through trucking services, through putting in additional water points, to engaging the private and the informal sector to provide some of those sanitation services such as latrine emptying and waste removal. In another group is the camps and the informal camps and migrant setting areas, and WHO together with IOM and UNHCR has some existing guidance. It's quite weak on WASH, so we've now provided a lot of updates about minimum water quantity, which is at a minimum 20 liters per day, but ideally more, as well as how some of the sanitation and waste services can be organized. And then lastly, of course, you mentioned the rural areas, and yes, you're right, because they're not in such, so far we've seen this virus spread quite rapidly in urban areas, but there's also examples in particular from the US where it's spreading also in rural areas. So they should not be forgotten. And I don't think that it changes any of the technologies or the approaches that we would use, but it certainly means at the national level, there needs to be high level advocacy to make sure that there's funds in place. Often the systems in such places, especially pipe systems, are much more expensive because the distances are quite wide and people may not be able to actually pay the tariffs that would allow for cost recovery. So I think a bit of innovative financing needs to be thought about in those situations, but certainly from the technology side, it wouldn't be anything different. And I would encourage you all, if you're interested in kind of, okay, what are some of those technologies or the approaches, AVAG, and I can put the link in the chat, has published a compendium of sanitation technologies as well as drinking water technologies. And it's really useful for getting a sense of what technologies would be useful both in healthcare facilities as well as in communities. So I'll stop there and see if Arabella has anything to add.
Yes, thanks, Maggie. I think you covered most most of the points. The only other one to mention is around the gender and disability in terms of vulnerable groups. As far as I know, WHO doesn't have specific guidance on that, but WaterAid, that's one of their main areas of work. And I know that WaterAid in Cambodia have been doing a lot of work on mainstreaming disability within WASH in healthcare facility service provision. If you do a quick Google for WaterAid's website, they have lots of information on that. And we're trying to adapt some of their slides and resources and integrate them into the WASH Fit training package so that the considerations around gender and disability and inclusivity are part of the whole process. So involving representatives from women's group, from local disability organizations, ensuring that infrastructure is adapted for those with disabilities, or any new infrastructure is built with those groups in mind. So I think WaterAid is a great partner for that. I don't know if anybody is on the call from Cambodia or even from WaterAid and has would like to share any experience. Otherwise, I'll look for some of the WaterAid resources and share those as well with you all. Alex, back to you.
Thank you, Arabella. Indeed, it is very important to underline all these issues, and surely it is not within the, say, conventional scope of WASH Fit that applies more to the healthcare facility setting, but we are also interested in knowing a bit more on the well-being of the communities, of course. So with this, I think we have ended the question and answer session, and I would like to give back to Arabella. Thank you.
Thanks, Alex. I don't know if Jean from WPRO, you wanted to say a few closing remarks, or have the floor for any other comments.
Hello.
Hi, Jean. Yes, we can hear you if you want to go ahead.
Yes. I'm looking for where I could show myself. Say hello. Hello, I'm Jean Peralta, the Coordinator for Health and Environment in the Western Pacific Regional Office of WHO. On behalf of WHO and the Regional Office, let me thank everyone in the countries for your active participation, and the organizers and speakers for the excellent support to this webinar. Dr. Sheen, our director, Maggie, Arabella, Dr. Hong, Togos, and Alex, thank you very much. As the title of the webinar mentions, we aim to stop the spread of COVID-19 by supporting the community, and especially healthcare facilities, in improving their access to safe hand hygiene practice and to basic water, sanitation, and hygiene services. The most recent WHO guidance on the role of WASH in the response to COVID-19 clearly shows how we can achieve a win-win situation by helping to combat this virus by reducing infection risk and at the same time helping healthcare facilities access the essential WASH facilities. As you have heard in today's webinar, WHO and UNICEF are providing us with the most complete and efficient WASH Fit tool, which has successfully been tested in many of our countries. It has been recently updated, and we look forward to its wider application, especially the implementation of the improvement plans for healthcare facilities. We will work with you further to make this happen, whether in advocacy or exploring financing for WASH Fit corrective measures and maintenance and operating expenses in healthcare facilities. The shared experiences, comments, and questions from the participants of this webinar inform us, but we also motivated us on how we are on the right path to achieve the 2030 goal of universal access to WASH services in all healthcare facilities in the region. Again, please accept our warm appreciation to you all Keep safe and stay healthy. Bye.
Thank you for those closing remarks. So with that, we'll close today's webinar. I'll shut it down in a minute or two, but leave the chat open just in case anybody has any last questions or comments to ask. Thanks everybody for joining today, and do keep in touch. And if you are not yet receiving the Washington Healthcare Facility newsletter, I encourage you to sign up, which you can do on the Knowledge Portal. There's an area to add your email at the footer bar. So we'll be sharing more information and resources via that newsletter. So do please sign up. Okay, thanks very much, everybody. Have a good rest of your day. Bye-bye.